Good morning again. So we're going to discuss necrotizing enterocolitis, something we all fear. You'll hear more about it as the day evolves, as well as other lecture topics come up that are pertinent to necrotizing enterocolitis. I'll review the epidemiology, clinical presentation, some management strategies that we employ, outcomes, and then some pathophysiology, and if that can give us a clue at all on how we can begin to think about preventing this disease. So for the epidemiology, I want to use a recent paper, 2009, using the Vermont-Oxford network data. This is I don't know if you're all familiar with that, but it's a consortium of NICUs, sort of like the NICHD, that you are a part of and submit data and outcome and values that are happening in your NICU, so you then be able to collate all this information and benchmark your data. And in this cohort, at over 2 years, they looked at over 71,000 babies from 500 to 1,500 grams. They defined necrotizing enterocolitis as having one in each category. For a clinical finding, they had to have at least one of bilious gastric aspirate, emesis, abdominal distension, or occult gross fetal blood. And then that needed to be coupled with a radiologic finding, pneumatosis intestinalis, hepatobiliary gas, or pneumoperitoneum. So this is what they found, and let's take a few minutes to kind of go over this table. So this is the rate of disease and mortality from NEC by birth weight category. So this is how they divided their birth weight categories from 500 to 750 grams, 750 to 1,000, 1,000 to 1,250, 1,250 to 1,500. These are the net ends, the number of infants in each group. Of that birth weight category who did not have necrotizing colitis, the numbers in which they did have necrotizing enterocolitis. Therefore, they were able to then calculate a risk of NEC, the percent of NEC occurrence. So you can see in this column that the younger or the lower birth weight that you are, the higher the risk of necrotizing enterocolitis. 12%, 9%, 5%, and then 3%. Then they looked at the mortality. So to read this chart, if you were in this birth weight category without necrotizing enterocolitis, you had a 34% mortality risk. If you had necrotizing enterocolitis, 42%. So what's important to understand here is even though you're more likely to die if you're younger with necrotizing enterocolitis, 42, 29, 21, 15%, the odds of dying, the odds of mortality for each of those birth weight category is actually greater the older you are, the more bigger you are. So that the odds of dying is 1.6-fold higher if you had necrotizing enterocolitis in this birth weight group versus 9.9 if you had necrotizing enterocolitis if you were in the bigger birth weight group. So that's the general epidemiology of necrotizing enterocolitis. This is what I had referred to before, which I think is important when we're thinking about strategies and approaches to feeding intolerance, in that those numbers just represent the definite necrotizing enterocolitis and the impact on that on mortality. But this is from our Delgan data, over 1,450 infants. And we'll review stages in a minute, but these were my end percents. So the stage 1, where we just ruled out suspected, but it wasn't definitive, so it didn't have the criteria I just reviewed, was about 27%. And then definite and surgical NEC, 5% each. So 10% for definite 2A, so medical with pneumatosis, to surgical 3B. That kind of falls in line with what we traditionally see when we look at incidences of NEC. But if you include all of those that we stopped and evaluated and gave antibiotics and exposed to radiation because of the concern of necrotizing enterocolitis, we were doing that in almost 40% of our infants. So it's not It's not benign our concern for necrotizing enterocolitis and the amount of times that we evaluate for this and the potential impact that the evaluation alone may have on the developmental course of the infant. So some of these next coming slides may be a review, but I want to make sure we're all talking sort of the same language. So signs and symptoms associated with necrotizing enterocolitis. So gastrointestinal, abdominal distension, tenderness, feeding intolerance, the presence of blood in stool, a change in the stool pattern, an abdominal mass, perhaps a fixed loop that you're feeling, an abdominal wall erythema. Systemically, the baby can be lethargic, increasing the number of apneas, respiratory distress, temperature instability, acidosis, glucose instability, poor perfusion or shock, DIC, or you obtain a positive blood culture result. Here, we've all seen these infants. Abdominal distension. This is from Dr. Newspaper recently in the New England Journal of Medicine, an excellent review of necrotizing enterocolitis, and an example radiograph demonstrating the pneumatosis intestinalis and hepatobiliary error. Here's another image of a bigger baby. You see a little bit better here, the abdominal wall erythema, and also some pneumatosis intestinalis and an extremely abnormal bowel gas pattern. Here's an example. It's actually a case we had in the NICU, which I thought was probably one of the best images I ever saw of hepatobiliary error. And this is the lateral view. And this is the AP view. I included this because when this case in our NICU, this baby was diagnosed with necrotizing enterocolitis, had the hepatobiliary error, and actually unfortunately expired rapidly, pretty quickly after the sort of presentation of the signs and the initiation of management for necrotizing enterocolitis. So we wanted to look back at that case and say, well, is there something that we could have done or thought about or seen earlier to help prevent that outcome? So I quickly looked at the literature, was asked to discuss that with the group, and I thought, well, outside of everything else we see, what does the presence of the hepatobiliary error, the portal venous gas, tell us? And surprisingly, it actually doesn't tell us a whole lot. The decision, this was a study in 2005 where they looked at the series of infants with portal venous gas, and their conclusion was that the decision for any operative procedure should be based on the severity of neck and not on the presence of portal venous gas alone. Because nearly half the infants with portal venous gas survive without any operative procedure. So it did not necessarily, the presence, increase the risk of mortality among the infants with neck. It was more, whether it was severe or not the presence of not having an operative procedure that was associated with a higher mortality. Kind of in line with that, and I'll discuss in a minute, is whether or not we even have other clinical predictors about the progression of neck that we can use to guide our management. This is a gross pathology of a resected segment of the bowel. I liked this image because you can actually see on the surface what we're seeing on the radiographs all the time, sort of the bubbling of the pneumatosis intestinalis, and then seeing that sort of within the submucosa here in the histology. So that's sort of what your bowel looks like when you have necrotizing enterocolitis. So I spoke about the incidence based on birth weight distribution. What about based on gestational age, excuse me, and your average age at onset? So the younger you are, the later you tend to present. So infants less than 30 weeks, and I'll show you another study with similar data. So these are pretty reproducible, this trend. So less than 30 weeks, average at about 3 weeks of age, they will present. 31 to 33 at about 2 weeks of age. And then, I don't know what happened there, greater than 34 weeks at about 5 days of age. I think that's important to consider because necrotizing enterocolitis is not one disease. It's not going to be one thing that causes this in all of our infants. And we'll discuss a little bit more about that philosophy. It's going to be multiple things that come together, and the relative risk of those things coming together impacting the baby to produce necrotizing enterocolitis is going to depend on a lot of things, and gestational age and maturity is likely one of them. You asked about term infants. So I went back, and I wanted to make sure that what I was saying and my impression wasn't different today than it was maybe a little earlier, and I don't think it is. So the onset I just showed is earlier. It tends to be within a few days, 5 days of life. The majority, not all the babies, but the majority of babies that are term infants have a predisposing factor: congenital heart disease, the need for resuscitation, sepsis, another congenital intestinal malformation, or severe IUGR. So if you think about those etiologies, presenting early, it's been proposed that this early predisposing factor in most cases suggests a common mechanism related to perinatal ischemic insult. So not necessarily the same, but maybe some process that happens early, and that's why when you're older in your term, your presentation is early. But just like I had shown before, just because they're bigger doesn't put them at less risk for the severity of necrotizing enterocolitis and the potential for mortality. Mortality can be as high as what we see in the preterm infant. The management of the term infant or the near-term infant or late preterm infant, I'll have to say, and we'll have panel discussions so we can open it up to everybody because there's going to be different styles. But I don't necessarily take a different approach. And we'll talk about the approaches. The one thing that our unit probably tends to do that's different is we will get a cardiac echo on these infants because of its high association with congenital heart disease, just to screen and make sure that that's not what's playing a role in the pathophysiology. But other than that, our approach is pretty similar. So the late preterm infant, nothing really out there trying to look at that infant maybe between 34 and 36 weeks of gestation and try to begin, just like they did for the term infants, tease out perhaps what might be different epidemiologically or exposures. There's one study that had the late preterm infants, but they coupled them in with the term infants. So as of right now, I can't tell you if there's been any evidence to suggest that that group at that developmental phase of intestinal development presents a different set of risks. So what are the stages that you often hear about, and especially in the literature? So stage 1, this is when it's suspected. So you have some systemic signs that you're concerned about the baby, some intestinal signs that show that the baby is not acting as it was before in the way it's tolerating the feedings. But when you do the radiographic exam, no pneumatosis, nothing very clear, maybe a mild ileus. So you're mildly suspicious, and that's suspected. 2A, mild, is similar to the above, perhaps a little bit more obvious changes in the physical exam. And then now you're starting to see radiographic evidence of pneumatosis. So 2A is your mild but definite neck. 2B, moderate, now you're starting to get not just some general signs of systemic instability, but now you're getting some laboratory evidence that the baby is ill, some acidosis, thrombocytopenia, your abdominal exam remains abnormal, and your radiographic findings, again, you see pneumatosis and maybe more extensive abnormal pattern. 3A is advanced medical neck. Now you have even more systemic findings. You're going a bit beyond just some laboratory derangements. Now you're looking at systemic changes. All of a sudden, your baby's now on some vasopressors to support blood pressure. Now instead of nasal cannula and CPAP, you're ventilating the infant. The exam is usually worse with edema, erythema, and induration, and then your radiographic remains quite abnormal. 3B is your advanced, everything above is 3A, except now you have evidence of free air, pneumoperitoneum, and your surgical colleagues is likely taking them to some operative procedure, which we'll also talk about. Okay. This is what I wanted to mention before, is that, well, as you progress through each of these stages, is there some clinical parameter that can help you with that, to help predict it? Because we all have the case that I just spoke about, where all of a sudden things changed and the baby expired, and you're thinking for a while after that, is there something that we could have seen? And so we talked about this as a group, as we often do, but there really isn't reliable studies or signs and symptoms that they can say, if your baby starts to evolve this or have this, whether it's a biomarker, a lab value, a physical exam finding, you know you're going to progress from your 2A to 3B, and therefore prepare for that and to start early or preemptively try to change that course. Unfortunately, nothing like that exists. And this was a large study that was supported by the Glaser Pediatric Network, and basically they came to that conclusion. It says it appears increasingly likely that clinical parameters alone will not lead to a significant improvement in our understanding of NEC. Future studies must focus on advanced biological parameters in conjunction with the clinical findings. And that's the challenge. We're continuing right now trying to figure out what those advanced biological parameters are. The best thing is just be in constant communication with your staff, including the surgeons, throughout the whole course, so that you're all very sensitized to potential changes that you're observing in the infant. But this was asked yesterday as well. How would you manage these infants based on stage with some of the questions? This is also from Dr. New's paper. Let's talk about the management, the treatment strategy. Suspected necrotizing enterocolitis, definite, and surgical. Well, suspected, close clinical observation, bowel decompression, some radiographs to maybe give you some idea of which way you're headed, some laboratory values, consider your blood culture, and consider your IV antibiotics. So to the right of that is actually my additions. So as I was reviewing this last night, I thought, well, what am I doing a little bit more specifically in the unit that we can share and discuss? So in the suspected necrotizing enterocolitis, we tend to fall into sort of two groups. The first is, yes, we'll evaluate, but often we have a minimum evaluation probably of 48 to 72 hours. We do that time frame is because we want to monitor first that the blood cultures we obtained were negative, in fact negative. We want to see the clinical course over those 2 days as we're waiting that out. And we want to see, and I put in quotes, some normalization of the bowel gas pattern if we felt that there was something that was suspicious on the initial one. So that tends to take us to about 2 to 3 days. And during that period, I would say that often we are on antibiotics. If at that point we feel comfortable, we'll resume everything previous care. We'll withdraw that and resume previous care. We do not use, and we can again open this up further a little bit later, we don't use additional sort of biomarker data like CRPs to help make this decision for us. But then we still have another category is suspected or strongly suspected, and that's it, that we're still not happy. We give the 48 to 72 hours. The radiographs remain mildly abnormal. The abdominal exam is not, normal. It hasn't normalized. But we can't say we have pneumatosis, but we still don't feel comfortable that, in fact, this baby does not have necrotizing enterocolitis. There's been plenty of studies, and many radiologic studies, not just for necrotizing enterocolitis, but plenty of studies about the sensitivity of an abdominal x-ray. And also just the disagreement between radiologists reviewing the same abdominal x-ray. So absolutely, I think there's a possibility you potentially may miss necrotizing enterocolitis. So if clinically we still don't feel right based on the data that we have, we will call it medical NEC, and we would continue to treat. Now, the duration of treatment in that situation can range anywhere from 7 to 14 days. It's really up to the clinician at the bedside and how strongly they felt about how everything was sort of brought together and how they were reviewing the data. So definite medical NEC. You do have pneumatosis on your x-ray, and the baby is exhibiting sort of the classical signs that we had just talked about. The treatment, and Dr. New suggested 7 to 2 days. We're in a camp that we still do 14 days. I think it's very reasonable, though, to consider 7 to 10 days, especially in light of what we know about what antibiotics do to the gut. So are we making things worse by doing a prolonged course or a 2-week course? We just don't have that information. But I know we're starting to discuss it more about whether or not 14 days are fully necessary or not. And then surgical and I should say, from even in the suspected, involve your surgical colleagues early. Just let them know about the baby, and so that if anything changes acutely and rapidly, they're aware of the family, and they can help you pretty immediately. And then surgical necrotizing enterocolitis. As you may know, there's a little bit of a debate, not a debate, maybe just a controversy about how to approach the baby who may need some surgical intervention, whether it's by a placement of a Penrose drain at the bedside or a laparotomy. And the studies have also been mainly by, if you wanted to look up 2 authors, it would be Moss and Blakely. I think they've written the most about it using the Glaser pediatric data, a randomized trial that I'll talk about in a minute, the NICHD data and the Vaughan data. But anyway, I think the bottom line is we still not sure what may be the best initial approach, because it's so confounded about decision making at the bedside and the level of illness of the baby. In this study, in the New England Journal of Medicine, they randomized to peritoneal drainage or laparotomy. And even though early on it looks like maybe there was a survival advantage to the perinatal drainage, overall there wasn't. And there wasn't also any differences about being able to reestablish feedings later, length of stay, or other short-term outcomes. The long-term neurodevelopmental outcomes are probably going to be what we're all interested in, and that data is just not available yet from this trial, or at least not that I'm aware of. But acutely at the bedside, right now, there could not be a definitive recommendation about going one procedure versus the other. And this is the study by Blakely, who also looked at this. And I think there was an earlier paper by Blakely that suggested that if you did have a Penrose drain placement, that you actually had worse neurodevelopmental outcomes. And that sort of made sense maybe because if we talk a lot about the inflammatory milieu and the potential of systemic cytokinemia and what that does to your brain development, and if you're sort of sitting in that a little bit longer rather than just going in, doing a resection, taking the baby out, I think clinically I do think the babies with the Penrose drain tend to be a little bit more ill. But again, it's probably confounding by association, and that's just the decision was based because of the level of illness severity and the decision to do a Penrose drain. Here, when they looked at outcomes, the referent group is the drain. So if you look at death or NDI, neurodevelopmental impairment at 18 to 22 months, the odds ratio is less than 1. And so is the confidence interval, suggesting that there was in fact improved neurodevelopmental outcomes in babies who had received a laparotomy versus a Penrose. But when they adjusted for other factors, but they also, then the third column is they adjusted by what they called the restricted cohort, and those were the babies that were too ill to go for a laparotomy. Once they removed all of those potential confounders, then you sort of lost that benefit of maybe the laparotomy enabled better long-term neurodevelopmental outcomes. Studies continue to be conducted. I don't think we have an answer right now what's the best procedural approach. So at this point, the incidence and mortality of NEC is highly predicted by birth weight, and that basic benchmark data are available. Clinical criteria do not adequately predict NEC progression. Surgeons most frequently, I think, still perform a laparotomy, at least in our institution, but that decision, again, is very confounded. And so until we have further long-term neurodevelopmental studies of these babies, I think it's going to be hard to be able to definitively say one way or the other. So what about the pathophysiology? I think you are going to hear a little bit more about that later, but it's really going to be this interplay of the nutrition that we provide, but nutrition because of what we know about breast milk versus formula, but thinking about it again in the sense of the immunomodulation, what it's doing to the intestinal development, what is it doing to the programming of the intestinal development, and the baby's ability then to respond to stimuli and antigen in an appropriate way. So, and then the immunity, the immune response, immune development, and the microbiota that's established there in the intestinal gut. And that sort of, you know, I work with somebody who talks about a diseaseometer. You know, it's going to be different for everybody. And that ratio and that interplay of each of these factors coming together is going to be slightly different for each baby. So it's not going to be the same across the board, but it's probably going to be an interplay of this. But that is why I think the theme of a lot of what I was talking about, and many of us, is that it's really being thoughtful about early interventions and early strategies. And we've, I think, explained why that early and taking more of a developmental approach. And so this thought and kind of thinking that way for a while now, I thought this paper was actually very, Gonzalez Rivera in 2011, I thought was actually very intriguing about this hypothesis, and maybe moving away instead of looking at our cohort of infants of neck and no neck at the time that they have neck, let's move back and look at developmental approach. Maybe we should start asking, sort of like when I told that anecdote story about the microbiome study I'm doing, is maybe we should start looking back and saying, why are some babies not getting neck? And maybe something about their development and exposures are going to help guide this. So Sartwell, I guess in the 1950s, he came up with sort of an epidemiologic approach to look at incubation periods for infections. And what he came up with is that if you have a disease that has a well-defined exposure or a specific point of exposure from which then the disease begins to sort of evolve after that, you can fit your variables in a log normal distribution. And so what we're thinking here now is in the terms of time to onset, following the exposure or birth. If there are ill-defined etiologies or sequential environmental influences that don't interplay with each other, you're not going to get that nice log normal distribution. So this group, which I thought was what they did was very interesting, is they took a cohort of infants and they started to plot out what I showed you already. They looked at the median age of diagnosis across gestational age. And these numbers should actually look similar, which is good, because I think that's the reproducibility of some of this epidemiologic data. So each of these gestational age categories, how many kids they had in each group, and what's the time to presentation. And then they did what Sartell did. They did a log normal distribution of the log day of diagnosis and then the percentage of the risk of necrotizing enterocolitis. And you can see that, in fact, it does follow a very tight log normal distribution. So they say this implies a single point of exposure that then initiates a chain of events. In this example, birth, because it goes all the way from the beginning, birth is a point of exposure. So they ask, and they sort of in their paper suggest, maybe we should start to scrutinize the biologic processes that begin in the immediate postnatal period. And that makes sense when we think about developmental biology. So now I want to go into some things that we've discussed the past couple of days, and you asked me to think about and discuss with you. So probiotics, I was asked about probiotics, and I said, well, I was worried about those very low or extremely low gestational age newborns and the risk of receiving live organisms. And there's been some reports of sepsis in babies receiving probiotics, but few. So I went back to the hotel room that night, and I get these table of contents into my emails, and I was just kind of reviewing what was out there in some of the journals. And there was a case report of a bifidobacterium septicemia in an extremely low birth weight infant undergoing probiotic therapy. So again, I think we just need to be cognizant of this potential risk. And this was literally, this just came out. So I think it's an ADC fetal and neonatal and fetal edition. So this is, I thought this was a great graph when they tried to describe what was happening. So this was an infant. Here's the time course along here. Clinical presentation, what they were doing with the feedings, the antibiotic exposure of the baby. They did measure CRPs and other things. And you can see that they were marching along on their feedings, gave breast milk, started introducing their probiotic. So at this point, what looks like about a little over a week, the baby started to have some physical signs of not doing well, was replaced on antibiotics, did have that initial course that we all give, was replaced on antibiotics, and then bifidobacterium was observed in the blood culture. So I think there's going to be strategies. I think it's going to be important. But again, we just have to be humble at the risk of our babies. Lactoferrin. Lactoferrin is a major whey protein in human milk. It passes through the stomach and is largely excreted in the stool unchanged. Has many properties, but most importantly, antibactericidal and immunomodulatory. So there's actually been only one major study that I'm aware of, and it wasn't for necrotizing enterocolitis. I couldn't find much as far as NEC. I found a lot of theoretical papers, a lot of papers proposing the benefit of lactoferrin in NEC, but none that actually studied it and studied it well. This paper came out in 2009, and I think this restarted the sort of interest in lactoferrin. Bovine lactoferrin supplementation for the prevention of late onset sepsis in very low birth weight infants or neonates. What this group did is they gave bovine lactoferrin or bovine lactoferrin plus LGG compared to controls. This lactoferrin or the lactoferrin LGG was given at orally, birth to 30 days of life. And so this is their outcome measures. So let's just concentrate on the lactoferrin right now, since I want to sort of disengage from the probiotic conversation. So the total late onset sepsis there in the second line for the lactoferrin group, 5.9%, in the control group, 17.3%. And the difference was statistically significant. And you can read below sort of the organisms that they looked at and sort of the relative risk for each of those organism types. When you looked at the risk of sepsis in the really small group, the less than 750 grams, so the second line from above, no cases in the lactoferrin, 61% in the control group, and then infants less than 27% or 27 weeks of gestation, 14% compared to 41%. So it seemed like a pretty strong signal for late onset sepsis. What about the other outcomes? They did see a lactoferrin group 4% compared to 11%. Statistically significant threat needing requiring surgery for threshold ROP. For NEC, they did look at this, a trend, I think, 1.9 to 6, 4.6 to 10. So of interest maybe in a trend. I think that's what's just another epidemiological principle. When you're reviewing papers, and there's papers that are powered for one outcome, and then you see these charts about secondary outcomes and whether it's significant or not, often the paper or the study was not powered for the secondary outcomes. To power for NEC, you would need lots of babies. And so that's the other, for the probiotic. To power for sepsis due to probiotic administration takes way more babies than what's been done to date. But anyway, so what shall we do? Well, we went to the Cochrane review because I couldn't find a whole lot of NEC. And I said, well, let me see if there's something else I just can't find. So they have a whole review, a PDF and everything to say, we didn't identify any trials that were potential for eligibility for inclusion. So the data is just not out there yet. There's some biological rationale for it, maybe some signal for the late onset sepsis. The studies aren't for NEC. There's a lot more to be done about whether lactoferrin is going to be a promising therapy or not. So we're still missing some definitive trial. And again, I think important to always consider when you're reviewing these trials, are you powered to answer your question? And most importantly, for our babies and families, what does it do to the long-term neurodevelopmental outcome? Because I think we've been had the lessons enough about instituting or employing strategies before we know that answer. Okay, so other issues. So the next few slides, I wanted to consider the questions that were raised yesterday. So feeding after NEC. Well, I think we have discussed this in the panel, and I wanted to make sure there wasn't anything else that I could find that would say differently. And I would have to say I stand hold about what we've said before. After necrotizing enterocolitis, breast milk or a standard premature formula. And hopefully breast milk. I think a lot of us are seeing that increasing in our units, which is great. There's just no evidence out there to suggest a routine hydrolysate formula, and plus the concern of a lack of appropriate nutritional content. Just like the glucose scenario that was raised at the end of Dr. Hayes' lecture, sure, there's going to be a baby that you're going to tell me about that you just couldn't feed no matter what. So I'm not going to take away clinical judgment in a case-by-case scenario, but as far as routine administration or thoughts about approach to patients after recovering from necrotizing enterocolitis, I think there's nothing to support right now the hydrolysates, and maybe routine administration of that actually might come at a cost. I was asked about PDAs and NEC. Well, I was more interested when I was thinking about what maybe that person meant in that question, whether an untreated PDA is related to the incidence of necrotizing enterocolitis. And there's, even though in animal studies and some bedside clinical studies, you can demonstrate perhaps a decreased mesenteric blood flow with a large or moderate to large PDA. But never has that been associated with the incidence of necrotizing enterocolitis. Rather, our treatments have been a little bit more consistently. So I just wanted to make sure we had that distinction in mind. Breast milk contamination, I was asked that, I think, on the first day. That is something that we don't look at all in our nursery. So yes, organisms can be cultured from the breast milk. Again, that's not routinely done. I guess some units are doing that. But how, I guess I want to raise, or I would raise to the group, is how do you decide what's an abnormal bacterial presence in breast milk? Some of that is supposed to be there. And so thresholds have been identified as far as how much bacteria or what bacteria. But again, I don't know how those decisions are made. Seems a bit arbitrary. And also, previously, you know, one organism can be beneficial in some ways and maybe not beneficial in other ways. It can have multiple actions. So, for example, E. coli. So to label E. coli as a definite pathogen may not necessarily be true. And then it's also the balance between these organisms. So I guess I just wouldn't even begin to know how to make those decisions about what breast milk is too contaminated and you wouldn't feed the baby. And so any risk, the potential risk for NEC, I found, I think, 2 papers, same group from China, discussing this. So their strategy is that they would remove the baby from the breast milk and not give the breast milk. And then they thought they saw perhaps a trend of increasing necrotizing enterocolitis in that group. Well, is it the reaction to not providing breast milk is actually putting these babies at risk more than anything else? I don't know how you would do this study. We don't routinely do this in our NICU. I think the presence of bacteria is probably not a bad thing in the breast milk, but until I get further guidance about how you would even begin to utilize that information, I wouldn't necessarily change my practice. Blood transfusions and the association to NEC. It's funny you did ask about that, because the first day I talked to Dr. New and Theodora about that. I'm like, you know, what about all this data coming in? Well, the blood transfusion association is usually defined as if you got necrotizing enterocolitis within 48 hours of the blood transfusion. Just like everything else, I think the reports are a bit mixed out there. But some groups are saying that it's happening anywhere between 15 to 25% of their population of getting transfusions and then getting necrotizing enterocolitis. I again raised the question, can this be confounding by association? You know, is this similar to saying that some of our babies get some disease because they have a UA line in place? Well, all our babies have a UA line in place. So how do you disengage an exposure that's common to all the babies to a side effect or a morbidity that we see in the NICU? And I'm not convinced any of these papers necessarily did that. But to go through the exercise, the possible explanations for an association would be immunologic, a transfusion reaction, or the age of the blood has been discussed as a possible. And we are a unit that, that keeps the blood so that we minimize the number of exposures to the baby. Maybe that's not a good thing. I can almost see that perhaps there's other things going on with that unit that the baby may not tolerate or may not like. Because it's the deformability of the blood cells, adhesion and aggregation, prothrombotic effects of the transfusion. Ferguson there below, I think we just wait for some more data, and I guess there is, he's got a study going on right now hoping to answer the question specifically about the age of the blood that you're providing and the risk not only to necrotizing enterocolitis but to other morbidities that we see in the NICU. So again, I think more information is needed before I personally change my practice. I don't make them MPO if I make a decision to provide blood. Again, it's another thing in the NICU that stops feedings in our babies, and I think we've already accrued enough of those lists. And so the current level of evidence is just not sufficient at this point. So finally, the short bowel syndrome. And sort of strategies with that. And in fact, the biggest predictor is how much bowel you have left, how much overall surface area you have. So this is also out of Boston Children's Group and Dorsky, who looked at the length of the small bowel, your number of patients, and your ability to wean, your probability of weaning on this side. So the longer your bowel that you have left intact, the higher the probability of weaning off your PN. But what was important in that transition and weaning from the PN? And it's everything that we have talked about. It's giving some energy and starting to feed sooner and earlier. It's providing breast milk and those substrates. Here they did look at an amino acid-based formula and saw some benefit in their kids with this. So the same principles, just like when we talked about special nutritional considerations, and we'll reinforce some of these principles at the end of the day, same thing happens here. There didn't seem to be an association. I was a little surprised there was no association whether or not they left the ileocecal valve intact or not. But other than that, those were the other things that were controlled for. And here you see that hydrolysate formula actually had no impact on this relationship. So another study is suggesting that hydrolysates are not necessarily going to be beneficial in this population. All right, thank you. Yes.
Thank you very much for this overview for NEC. I would like to ask you, there are outbreaks of different kinds of NEC, starting from blood only in the stool and stage 1 necrotizing enterocolitis, as you mentioned it, up to stage 3B. And there are outbreaks in units out of the blue. We and others have had these problems. And we actually don't know what has happened and why we had it. We have tested everything.
Yeah.
At the beginning, we thought it might be infection, yeah? Not bacterial infection because cultures were all negative. Possibly a viral infection. We have tested all possible viruses that we could do. No virus was found. And this thing went away as it came.
Yeah.
Can you comment on that?
I think you said everything that I would say, is that it would tend to lend a supportive argument to an infection or something, that it was transmittable. But the inability to isolate any single organism has had us fail to be able to say conclusively that that was going on. It could be something that we aren't able to culture. I don't know if there are viruses that have been associated with necrotizing enterocolitis, like rotavirus.
We had the rotavirus, but no rotavirus was found.
So, right, I agree. I don't have an answer to why these clustering occurs and what may be causing that. Yeah.
Thank you for your excellent talk. I raised the question yesterday about the influence of blood transfusions and NEC because I was in a meeting in Vicksburg last October, the beginning of last October, and there was a very well-known hematologist from the States. I can't recall his name.
Dr. Christensen?
Yes. So he gave a full talk concerning the blood transfusions and the incidence on intracranial hemorrhage and NEC. And what he presented was that the red cells, if they're fresh, they have two capacities. One is when they go through narrow vessels to produce locally nitric oxide and increase the width of the small vessels. And the other is that they are able to change their
Deformability.
yes, exactly,
Right.
their scheme. So if we use blood, which is not that fresh, it's of some days old, then if they go through the brain vessels, they have lost their capacity to produce local nitric oxide, and they can't change shape, and then they go there, and they are just stuck, and the vessels may just get swollen, then they break, and you have the bleeding, and probably in the same way he mentioned that they go and they just, the red cells, they go through the small, tiny vessels and they get stuck, and probably they are interfering, let's say, in the gut and produce local ischemia. They can't. That was his explanation. But
yeah.
I was really
No, it's
and it was completely new to me. That's why
right.
I asked that.
Yeah, no, fair enough. Thank you for the update and sort of what he proposed. I guess right now it's a good theory, and until I think we're able to measure that and see it, or maybe look at some animal models for it. I just think before we start being able to say that this is a definitive association and change the way we right now look at blood transfusions and manage around the time of receiving transfusions, I'd like to just see that there's more data to support these theories.
And I'm not sure, I don't know if I'm allowed just to present a few data from our unit. I work at the Mitera NICU as a director for 28 years actually. And we have very good survival rates on NEC. Actually, for 25 years, we had no deaths on surgical NEC. And then it happened when a new surgeon entered joined the surgical team, we had 3 or 4 deaths. And that was all. And our survival is really very high, even on the tiny ones. We don't use either pro or prebiotics or probiotics. We go slowly. We probably keep them NPO for a few days, not that many though. We never exceed the 2 weeks of antibiotics on the very sick ones.
Right.
On the, let's say, 2A, about a week or so, but our results are really good.
Excellent. Thank you very much.
In our unit, we used the amino acid-based formula for 1 month before post-surgical condition in every newborn's, in every condition regarding the gut, post-operation regarding the gut. There is any clinical evidence about this because we suspect an altered permeability in these newborns.
Yeah.
So
No,
I would like to know your opinion.
Yeah, you know what, and I think that's great, and thank you for sharing that. You know, what I would love, what I think the dream would be, is there an ability, we've started it a little bit with the NICHD and the VON, but instead of what seems like sort of sometimes trial and error medicine, and sometimes what it seems like you have to wait for the funding for large comparative trials, I would imagine that in today's world and the technology that we have and the information systems that we have, we should be able to be collecting this data real time in our babies and doing sort of real time quality improvements and looking at the data to see what's happening and accrue this evidence and turn it from sort of anecdotal to more of a sharing of the knowledge and the data that you see. And then so we don't go through the same series of steps in a baby before we figure out what works. We're a little bit smarter about the experience that we're accruing. So I appreciate that. I guess I wish there was a way in which we can all inform each other a little bit better so that we can actually study this without relying on prolonged, expensive trials.
Practical questions. How much fluid, the volume of fluids that we have to give for babies with NEC?
When you're NPO, when you're on PN?
Yes.
Yeah, I think we're in the range that Dr. New was suggesting before, about 100 to 120 mLs per kilo per day of nutrition provided by parenteral nutrition, yeah.
What about feeding the babies after the NEC with the standard formula? Do you see any rationale to dilute the standard formula if you don't have breast milk?
Yeah, no, I think that is something that we'll routinely use first if breast milk is not available, saving the hydrolysates and the amino acids for sort of unusual situations, but not routinely, especially with the hydrolysates not providing sort of the nutrition that you want to ultimately provide. Yeah.
You would dilute it.
Oh, dilute, is that what you asked?
Dilute,
Oh, I'm sorry. No,
dilute
no,
it.
no.
No.
Full strength. We don't dilute in our unit. Yes.
Thank you.
Sorry.
Do you follow any specific protocol for feeding full-term severely affected IUGR infants?
No, we do have a protocol based on birth weight. So if they are so severely restricted that they fall in our categories of different birth weights and advancement based on birth weight, we'll follow that. But otherwise not specific for the IUGR infant advancement protocol. Yeah.
Full terms.
Yeah, exactly.